So, ganyan guys, thank you for your time. Thank you for your time to watch this video. I hope makatulong ito for your midterm exam and not just for your midterm exam, for your future RLE. Uh, at least kung na-encounter nyo man ito sa hospital or any uh, areas na relate sa maternal, you will, tawag dito, basta maalala nyo. Okay, nawawala na yung sentence ko. Okay? So, maalala nyo itong mga bagay na to. So, let's start. Since konti na lang siya, guys. Okay, so we have, since nag-stop kasi tayo sa fetal distress eh. Diba? Excuse. We are done with your, di ba, yung late deceleration. Naalala nyo yan sa prelims. So, I think okay na tong fetal distress. So let's move on sa ating prolapse umbilical cord, okay? Pag prolapse umbilical cord guys, ito ay, for example, we have case na it is a term but hindi pa talaga niya expected date of delivery. So, biglang nag-prolapse na yung umbilical cord ni baby, di ba? Supposed to be si fetus muna bago si umbilical cord. But ang nangyari is, nauna si umbilical cord before the fetus. So sabi dito, cause is fetus is not firmly engaged, di ba? Hindi pa i-engage pero open ang cervix, lumabas na yung umbilical cord. So, ano ba yung mga contributing factors niya, di ba? We have range of motion before engagement, di ba? Small fetus pag maliit, nauna tuloy ang umbilical cord, di ba? Or breech presentation, di ba? Pwede din. Pwede mauna yung cord. Or multi-fetal pregnancy, di ba? Pagkambal or uh, quadruplets, triplets, yan. Then transverse lie. Pwede din. Baka mamaya maging abruptio placenta pala to, no? So, pwede din prolapse umbilical cord din. Then polyhydramnios long cord, pag mahaba masyado. Spontaneous or artificial rupture of membranes before presenting part is engaged. Okay, bigla-bigla na lang. Hindi ko pa kabuhanan, ganun pa ni mother, pero lumabas na yung umbilical cord. So what are the assessments? We have to identify the client at risk for prolapse umbilical cord. Okay, and then we have to assess the fetal hypoxia, di ba? Which is the fetal distress. Kung nagkakaroon na ba ng hypoxia, di ba? Bumababa na yung oxygen level ni baby. Then, irregular, ano yung FHR? Fetal heart rate. And then we have umbilical cord can be felt on cervix or vagina. Kasi prolapse nga, from the word prolapse, lumabas na yung umbilical cord. Then variable deceleration. Then we have cord, maybe protruding, di ba? Medyo redundant na. Nag-protrude na, lumabas na yung umbilical cord, nagkakaroon ng fetal distress, fetal bradycardia. Parang isa lang halos lahat yung ibig sabihin, no? Then, so, when doing nursing diagnosis, pwede tayo mag-ano ng risk for impaired gas exchange. Kasi nga, di ba yung umbilical cord, lumabas na. Pwede din risk for injury. And syempre, may fear kay mother. Diba? Mabubuhay kaya anak ko or hindi? Yun yung nasa isip niya. So what are the nursing responsibilities or nursing management? Note, the number one priority is the fetal heart rate. Diba? We look for the fetal distress. Diba? Fetal hypoxia, irregular FHR, fetal distress, we have fetal bradycardia. So what are the primary goal? To remove the pressure from the cord. Okay, wag nating ipitin, di ba? For example, sabi na lang natin, ito yung umbilical cord. Pag inipit po kasi natin ganyan, di ba? Placenta is presenting the blood flow. Di ba? Kung ano yung pumapasok kay mother, yun din yung pumapasok kay baby. Kumbaga, yun yung daluyan, yun yung connected sa heart ni baby tsaka ni mother. So, pag naipit ang cord, hindi na nakakadaloy na maayos yung blood. Okay? So, kailangan, tignan natin, i-check natin. Nag-a-IE na dito si Doc para hanapin niya kung saan yung pinag-ipitan ng cord. So, planning and implementation. Guys, place daw si mother in niches or Trendelenburg position. Paano yung niches? Diba? Ito yung, for example, ito yung knee. Niches. Tapos, pasay. Okay? Niches. Diba? Para siyang fetal position din. Yung knee mo, ilalagay mo sa chest mo. Kahit malaki yung tiyan ni mother para maganda yung blood flow ni baby. Or Trendelenburg position. And then push fetal presenting part upward, hindi po downward. So please take note, do not push cord back to the uterus. Huwag niyo po isasoli, guys. Baka magkakaroon pa ng lalong problema yan. May iipit lalo yung cord. So pag ganyan ang case, usually lumalabas po guys ito sa board exam na tanong ito kahit ulitin po nila ilang beses. Pag lumabas po ang cord, anong gagawin? You have to, yan, if cord protrudes through the vagina, apply saline soak dressing to prevent drying. Okay? Yan po ang gagawin nyo. Number 1 na gagawin pag nag-protrude na ang umbilical cord sa may labia majora. O, diba? Para medyo maganda pakinggan. Oh, you have to soak the dressing to the saline solution para hindi po mag-dry. Ipapatong nyo lang doon. Ibabalot nyo lang po yung soak OS doon. Then, maintain or administer oxygen by face mask at 8 to 10 liters per minute kay mother. And then, maintain continuous electronic EFM, electronic fetal monitoring, and then prepare for rapid delivery vaginally or by CS. Okay, kung naka G2, G3, G4 na yan, pwedeng kayang-kaya ang NSD or the normal spontaneous delivery, or pero kung prime yan guys, syempre hirap-hirap pa yan, pwedeng emergency CS. Okay? So evaluation, the fetal heart rate remains within normal range and without ominous signs. The fetus is safely delivered, and the client and the family verbalize understanding of the implications of prolapse umbilical cord and the need for emergency management. So that's the prolapse umbilical cord, diba? So yan yung mga abnormalities, and then the fetal distress. Diba? So let's move on sa problems with the passageway. Saan nga ba dumadaan ang fetus, diba? Sa may vagina, pero we have called this pelvis, diba? Yung bewang natin. Malaki ang bewang, pero yung buto is maliit lang ang paglusutan ng fetus, di ba? O ganyan. Tapos lalusot yung ulo ng bata, or depende kung ano ang presentation ni fetus. So we have abnormal size or shape of the pelvis. Okay, iba ang ng balakang sa buto niya ha, the pelvis bone. Pelvic bone, sabi pa nila. So we have 3 types actually: inlet, mid-pelvis, and outlet. Okay, so pelvis is said to be contracted when its diagonal conjugated is less than, okay guys, itong size 11.5 centimeters, and its ischial diameter is less than 8 centimeters. So we have 3 types. Let's see kung ano ba ang passageway ng mga ating pelvic. We have inlet contracture. Okay, inlet dystocia, di ba, from the word dystocia. Hindi po kakasya ang kanilang shoulder. Okay, inlet dystocia. Anteroposterior DM less than diameter to guys. Anterior-posterior diameter less than 10 centimeter. Okay? Eh di ba normal natin dapat is 11.5 and then less than 8 centimeter daw ang by ischial. Ito, anteroposterior diameter less than 10. Bababa ng 10, and greatest transverse diameter that is less than 12. Masyado namang malaki. Or diagonal conjugate less than 11.5 centimeters. Okay? Pag naka-transverse, di ba, transverse, naka-horizontal. So talagang malaki. So kakasya ba yan sa ano? 'Di ba? Parang tinupi mo naman na yung bata pag nasa pelvic na. So pag inlet 10, 12, 11.5. Okay? 10, 12, 11.5. Supposed to be dapat 11.5 ang diagonal niya. And then, by ischial niya is 8. Okay? Due to several conditions including rickets and flat pelvis. Diba yan? Yan yung sinasabi yung flat-chested, diba? Flat buttocks or flat ass, sabi pa nila. Basta bahala sila. So usually, ano to, common sa mga preemie, di ba? Lack of engagement between 36 and 38 week of pregnancy. Influences fetal position and presentation. So that's the inlet contraction. Okay? Malaki, masyado. Okay? Though normal yung kanyang diagonal conjugate diameter, pero yung kanyang anteroposterior and transverse is na. Okay? How about mid-pelvis contracture? Occurs when the sum of the interspinous and posterior sagittal diameter of the mid-pelvis, pagitan ng mid-pelvis, is less than 13.5 cm or masyado malaki, no? Interischial spinous diameter less than 8. Okay? So, di ba ang normal ng ating biischial is 8. Ito kasi interischial spinous. Okay, so mid-pelvis dystocia is the most common pelvic dystocia. Guys, di ba sumasabit ang shoulder ni baby upon rotating, upon the 7 cardinal signs of delivery, di ba? Supposed to be, dapat engaged na siya. So, pag pumasok na yung ulo ni baby, dapat matigas na yung symphysis pubis ni mother, di ba? Pag kinapa, yung above symphysis pubis, ginaganyan, dapat matigas na siya. Usually, pag ganito ang cases, engaged but due to narrow diameter of the mid-pelvis, nagkakaroon ng prevention from rotating internally from transverse to anteroposterior diameter. Okay? Kasi nga, ipit. Hindi kasya. Kaya usually pag ganito yung mga cases, guys, delivery, ano type ng delivery is cesarean talaga. Huwag natin pilitin, guys, kasi may naging pasyente kami noon na parang ano yun? Inaako sa ospital yung kasalanan kasi yung shoulder ng anak niya, gulat sila ba't di kayo gumagalaw yung isang kamay. Tapos ito, naka-rest, nakaganon lang. Tapos ito, parang hyperactive. So, chinek nung ortho, may dislocate ata, gawa siguro nung upon doing the normal spontaneous delivery, na na-affect tong shoulder niya. 'Di ba? Narinig yun, 'di ba, yung shoulder dystocia? So usually ayun yung sa mga mid-pelvis contracture, yan, mid-pelvis dystocia. Most common pelvic dystocia. So ayan, guys, masyadong malaki naman pag mid-pelvis. And then pag sinabing outlet, occurs when the biischial diameter distance between ischial tuberosities is less than 8 cm. Less than 8 cm. Okay, yung distance between the ischial tuberosities. Okay, so what are the causes kung bakit ngayong gantong cases tayong na-encounter, di ba? So, okay. So, what are the causes? Increased fetal weight, di ba? Biglang paglaki ni baby inside the womb. Biglang laki ni fetus inside the womb of the mother. Di ba? Fetal position nag-change. Di ba? Dati cephalic, tapos naging ridge. Or pwedeng transverse. Di ba? Kasi pag pinahilot, pwede din. Problems with the pelvis. Walang problema sa bata, pero sa pelvis ni mother, yes. Kaya nga, di ba naalala nyo nung case presentation, tinanong ko na maliit ba si mother? Di ba? Kasi pwedeng maliit si mother, malaki si baby, pwede magkaroon ng dystocia. Kasi nga, large size of baby uh, can move to the passageway of the uh, pelvic ni mother. Okay? May kaya sinasabi natin pag maliit ang pasyente, may tendency po na kakaroon ng complication. Kaya high risk din po sila. Kahit tama yung age, di ba? Maganda yung diet. Kung maliit ang kanyang pelvic bone, doon tayo kakaproblema. So, yan, category, sabi nga, maternal, syempre, size ni mother mo, di ba? Yung bony pelvis, bony pelvis. Yan, bony pelvis, di ba? Size and shape ng kanyang pelvis. Kahit mataba ka, pero ang lit-lit naman ng pelvis mo. Okay? Kasi usapang buto to, guys, hindi usapan ng haba. And then the fetal, di ba? Kung gaano kalaki si baby, kahit ang laki-laki mong tao, pero kung ang laki din ni baby, di ba? Parang macrosomia, kaya sinisias ko agad yun. So, this is the clinical pelvimetry. So, pag green, ito, conjugated. Pag ganyan, di ba, transverse, tapos oblique. And then, um, interspinous. Okay? Interspinous, usually sa ano, di ba yan? Sa ano naman yun, guys? Interspinous. Sa ating mid-pelvis. So, ayan. Di ba, guys? Hindi ko alam sa mga nahawakan ko, kung nasa group ko man nandito, hindi ko alam kung napansin nyo, di ba ginaganon? Inaano yung pepet ni mother, ganyan. Tapos, tinatry ibaba. Okay? Kasi, yung buto na yun, hindi naman natin ma-adjust. Kaya nga, di ba, ginagawa natin episiotomy, kahit nagkasya yung head, pero pagdating doon sa labia majora, hindi kasya. So, nagugupit tayo sa perineum. So, ayan. Hanggang dyan lang kasi hangganan, guys, eh. Usually, ganyan, di ba? Ginaganyan. Tapos, binababa, tinatry. Okay, yan. Measurement of transverse diameter of the outlet and pubic angle. Sinusukat kasi yung ulo ni baby kung kakasya ba doon. Okay? So, ito yung sinasabi namin nung sa late deceleration. If you remember, di ba, the TOL, the trial of labor. The physician may allow labor to continue or even stimulate labor with oxytocin when pelvic measurements are borderline to see if the fetal head will descend, making vaginal delivery possible. If progressive changes in dilatation and station do not occur, a cesarean delivery is performed. Pag hindi nag-adjust, kahit nag-trial labor ka na 24 hours, same pa rin, di ba? For example, 7 centimeters. After 2 hours, try nyo mag-trial of labor. Wala pa rin adjustment hanggang umabot ng 24 hours. Na hindi pa rin nag-adjust, they will perform cesarean delivery to the patient kahit ayaw niya. Kasi nagkakaroon na ng fetal distress. Okay? So, next, we have cephalopelvic disproportion. Diba? From the word cephalopelvic, pelvic disproportion. Fetal head is too large to pass through the bony pelvis. Hindi kakasya yung ulo ni fetus sa bony pelvis ni mother. So, sign is masyadong malaki. Meron kasi guys yung mahaba. Meron din yung malaki, malapad. So, magkaiba po yun guys, ha? So, maternal risk, prolonged labor, exhaustion, hemorrhage, and infection. So, what are the fetal risks sa mother kanina? Ito naman sa fetus. Hypoxia, di ba? Fetal distress. And then, birth trauma. Tama sa ulo. Okay, and then diagnosis, ultrasound. Pwede natin makita through ultrasound. Estimation of the baby's size can be made and an assessment of potential cephalopelvic disproportion can be made. Okay? Pwede na natin siya early diagnosis. Kung sakto the day ng mga anak siya, doon na ultrasound. Mas maganda malalaman agad. So the management is cesarean section is the only option to deliver the baby. Okay, wala nang iba. Kasi kung malaki ang ulo ni baby, hindi ka kasya sa pelvic as well. Lalong-lalo na yung shoulder, di kasyang-kasya, di ba? So, kakaroon ng problema doon. Then we have shoulder dystocia. Difficult in bringing out shoulder or fetal head is born but the shoulders are too broad to enter and be delivered through the pelvic outlet. Okay guys, wait lang ha. Ano na yun? Wait lang, antayin niyo ako. Okay, guys, let's go back. Sumakit yung tiyan ko. Okay. So, ayan guys. Shoulder dystocia, ito yung paul ko kanina. Kahit magkasya yung ulo, paano kung yung shoulder niya? Diba? So, the fetal head is born, but the shoulders are too broad to enter and be delivered through the pelvic outlet. So, kahit mag-episiotomy tayo hanggang third degree, hindi po kakayanin kasi ang usapan dito is pelvic outlet. Okay, so the manifestation is prolonged second stage of labor. And then arrest of descent. Okay, hindi makapag-move yung cardinal signs natin. Okay, and then the turtle sign. So, kindly search na lang the meaning of the turtle sign, kung anong klaseng turtle sign yan during the labor or the delivery card, guys. Then the maternal risk, we have vaginal or cervical lacerations. Mahaba-haba, diba? Hanggang anus na ang punit. And then postpartum hemorrhage. Ito po yung iniingatan natin, guys. Pwedeng magkaroon ng bleeding, excessive bleeding sa mother pag ganong case. Okay, so that's the maternal risk. How about in neonatal or the fetal risk? We have hypoxia, di ba? Hindi nawawala ang ating fetal distress. And then fractures of clavicle. Clavicle, it's either dito kasi dito sa clavicle or sa shoulder ng bata. Kasi pilit. Okay? So, pwede din magkaroon ng brachial plexus injury. So, ano po ang brachial plexus injury? It is a group of nerves that come from the spinal cord in the neck and travel down the arm. These nerves control the muscles of the shoulder, elbow, wrist, and the hand. So, yan yung sinabi ko, guys, di ba? Hyperactive yung isa, pero yung kabila, hindi. So, yan yung brachial plexus injury. So, sabi naman usually ng ortho nga, kung minor injury lang yan, pwedeng gagaling din after how many weeks yan. Pero magkakaroon din ng permanent disability some of cases. So what are the nursing care assessment and identification of the client at risk for the shoulder dystocia is yan, obesity, increased fundal height, biglang lumaki, history of macrosomia. Kaya nga, di ba, pag CS lang talaga. Then, if ever ba may gestational diabetes si mother, dating may diabetes na si mother. Prolonged second stage of labor. Di ba, lumabas na yung ulo, pero yung shoulder ni baby, hindi pa. Tapos multipara. Okay? And then, post-date pregnancies. So, what are the nursing diagnosis? Siyempre, number 1 is risk for injury. Kasi, baka magkaroon ng injury. O, di ba, sinabi natin, fear, takot na lumabas, 'di ba? Or deficient knowledge, 'di ba? Ano ba tong klaseng ganito, 'di ba? Kailangan alam ni mother. So, planning and implementation, we have assist with positioning during delivery of Macrobert's maneuver, guys. Macrobert's maneuver, usually, woman flexes thigh on her abdomen, 'di ba? American setup, di ba po nanganak sila, yung knees nila usually nasa abdomen, di ba? Knee chest, parang dating gano'n. Then position changes the angle of the pelvis, increase pelvic diameter, and facilitates the delivery of the shoulder. Di ba kaya meron yung mother gumaganong-ganong pa yan? Tinatimingan nila kung paano. Di ba? So ayan, sabi diyan, pag before macroverse positioning, diagonal orientation of symphysis makes shoulder delivery difficult. So, kailangan i-tilt mo daw yung pelvis. Pag i-perform ang macroverts, you have to tilt the pelvis, orienting symphysis more horizontally to facilitate shoulder delivery. Di ba? Ito na yung ulo, tapos mag-slide down and then palabas. Okay? And then assess for maternal and newborn injury following delivery. Pag lumabas, tignan natin kung may mga possibilities magkaroon ng brachial at brachial plexus injury. Okay, and then evaluation, we have client and fetus experience a safe delivery without injury. Yan dapat yung mga lalabas, yung mga mag-goal-met natin. The client indicates that fear is diminished. Okay na ako kasi nakita kong healthy yung anak ko. Client is able to verbalize increased understanding of pelvic disproportion and dystocia and its causes and implication for the delivery. Gagawa kayo ng mini ano yan? Discussion about dyan para aware si mother. Ganun pala. Okay? Then last, we have problems with the powers. I think last na to. Yeah. This will be the last. Okay? Wait lang. Okay, so last we have the problems. Kanina problems with, tawag dito, problems with the passageway, yung dadaanan ni fetus. Dito naman is power, power sa pag-ire. Okay? So we have difficult labor. Talagang meron yan, lalong-lalo na sa mga preemie. Talagang magkakaroon difficult labor. Minsan tinutulugan. Diba? So actually we have four kinds of difficulty in labor. Okay, so first we have hyper, from the word hyper, diba? Hypertonic uterine dysfunction. Usually encountered in the latent phase. Kalagitnaan po ng panganganak, contraction are too frequent but uncoordinated, tend to be more painful. Diba? Sunod-sunod na yung pain. Usually sa partograph, makikita mo na yung prolong or yung tagal nung pag-contract. Unlike nung una is after 2 minutes, rest. Tapos, after ano na naman, after ilang minutes, 2 minutes, magko-contract, tapos magre-rest. Dito kasi is super hyperactive na nung contraction. Nagpapairi na si baby. Pero, minsan meron yung mga mother na ayaw umire. Diba? Iyak, iyak na lang ang kanilang ambag. So, maternal days is prolonged or non-progressive labor, pain, and fatigue. Usually, guys, pag ganyan kasi pag nagko-contract ang instruction natin sa mother, pag kumikirot ang tiyan, pag naghihilab ang tiyan, you have to try to push, di ba? Meron kasi, ayaw na, sakit, di ba? Umiiyak, mas inuna pa umiyak, hindi na lang naawa sa anak. Di ba? So, usually mga ganyang bagay, pag nagpapakontract kasi, kailangan i-ire. So, kaya nga, pag tumagal ang labor niyan, nagkakaroon ng fetal distress na. Di ba? Hindi dahil naipit ang cord lang, dahil gusto niya na magpalabas. Gusto na lumabas ni baby. Diba? So, the maternal risk is prolonged or non-progressive labor, pain, and syempre, pagod na siya. Diba? Ba't di nag-adjust? Kasi may proper way talaga na iire. Meron kasi umiire, lumalaki yung leeg, di ba? Hindi proper yung kanyang pag-ire. Meron din yung pag-ire dapat sa baba yung puwersa. Di ba yung nagbabulge yung kanya? Para sabihin, itae mo yan, mother. Di ba? Ganun dapat ang umire. So, fetal risk is hypoxia caused by decreased uteroplacental blood flow. Di ba? Contract na i-stop yung blood flow ni baby. Kasi nagpapalabas. So, the medical management is therapeutic rest. Kailangan pahinga. Diba? Sedation aim at stopping contraction. Kailangan bigyan natin siyang pampakalma. Kaya binibigyan siya ng hyoscine. Diba? Ano ba ang effect ng hyoscine sa inyo? Hyoscine means yung buskupan nyo yan, guys. So, hyoscine para mag-stop yung contraction, and then para makapag-rest din si mother, para makapag-ipon ng lakas, para ma-allow natin na mag-normal labor si mother. Okay? So, papatulugin lang siya, yan, pag-restin lang. So, para hindi siya ire ng ire or hindi siya aray ng aray. Okay? So, evaluation of pelvic size, kailangan gawin natin, monitor po natin intake and output kasi most of the mother bilang nagsusuka. Okay? The maintain of fluid electrolytes, keep bladder empty, encourage side-lying position. Suppose, ano po ang usually nire-recommend natin pag side-lying, di ba? Less. Kasi nga, to the, toward the heart, di ba? Toward ba? Basta bahala na yun. And then watch for danger signals or danger signs like fetal distress, passage of meconium stained amniotic fluid. Okay? Dapat intact pa rin ang bag of water ni mother para hindi magkaroon ng infection. Okay? That's the hyper. Diba? Contract ng contract. Pero pag sinabi natin hypotonic uterine contraction, pag hypotonic, characterized by weak and infrequent contractions which are insufficient to dilate the cervix. So, weak and infrequent contraction. Hindi tama. Minsan may 2 minutes, minsan may 1 minute, may umabot na 3 minutes. Hindi siya gaano. Tapos, after 1 hour, ganun katagal yung stage yung contraction niya. So, usually occurs during the active phase, di ba? Pag sinabi kasi natin active phase, guys, false labor pa siya, di ba? O, nay, kaya mo pa lumakad. So, usually, yan yung hypotonic. Baka nga, minsan sa bahay, kailan po nagko-contract yan? Di ba? Ganun ang question na. So, what are the causes? O yan, over-distension of the uterus, malpresentation and position, pelvic bone contraction, unripe or rigid cervix, and congenital abnormalities of the uterus and unknown causes. Usually, hindi natin alam. Okay, so what are the risks? Maternal and fetal infection, yes. Postpartum hemorrhage, kasi nga ang tagal. Fetal distress and death, dahil sa katagalan ng contraction pa. Eh, maternal exhaustion, di ba? Umabot ng 3 days ang labor, Diyos ko, dahil. Kailangan mag-decide ka na kung ino-normal mo ba o isi-CS mo. Okay, so management. Re-evaluate pelvic size to rule out fetal-pelvic disproportion. And then vaginal delivery, amniotomy if membranes are not yet ruptured. Pag intact pa ang bag of water, pwede mong butasin. Then augmentation of labor. Then, pag masyado matagal na, CS if pelvis is contracted. And then, syempre, kailangan ng support from the family or loved ones. Yan, provide supportive nursing care. Then, we're done with hypertonic ba? Yan. Ayan. Hypertonic and hypotonic. So, let's move on sa ating abnormal progress in labor. So, the partograph, okay guys. So, yan yung sinasabi namin no, is presentation graph na nasa isang papel. Maliban sa electronic fetal monitoring, diba, yung partograph. The partograph is used to identify deviation from normal progress in labor by plotting cervical dilatation and descent of the fetal head over time. So, we have prolonged latent phase, diba? Kalagitan ng panganganak. Medyo mahaba yung kanyang contraction. So, exceeding 20 hours in nulliparous. Pag sinabi natin na nulli, di ba, first time mothers. And then more than 14 hours, yun lang dapat ay itatagal nung kanilang latent phase, di ba? Dapat within hours na to, ito lang yung range na dapat within 20 hours manganak na si mother pag first time. Pero pag multi-para, pag marami, 2 to more than 2, 14 hours lang dapat ang kanilang duration for delivery, okay? Or labor. So what are the causes? We have poor cervical condition, unripe, rigid, and firm. Excessive sedation, yan. Lagi mo pinapatulog si patient. And then conduction of analgesia. Okay, analgesia yung mga analgesics po na. And then management therapeutic rest. Use of sedative, diba? Usually, hyoscine, yun nga, HNDB or the Buscopan. Then active intervention, oxytocin stimulation, diba? para tulungan niyang mag-contract na maayos ang ating feeling buntis. Ang uterus ni mother, binibigyan na po siya, ini-incorporate po sa swero ni patient yung oxytocin para magkaroon ng oxytocin stimulation. So that's the prolonged latent phase. How about protraction disorders? So the most common abnormalities during the active phase is the protraction disorders. It caused by the same factors that contribute to prolonged latent phase. So we have two types daw sa protraction disorder. We have protracted the active phase and protracted descent. Okay? Pag sinabi natin protracted active phase, we have less than, okay, 1 to 2 centimeters dilatation per hour in NALI. Pag primary, 1.2. Pero pag multi, 1.5 per hour. Per hour to guys, hindi per day or after 6 hours. Ganyan, hindi. Per hour, okay? So that's the active phase, protracted active phase. How about protracted descent? 1 cm for the NALI and 2 cm for multipara. So una is 1.2 and 1.5. Yung isa is 1 tsaka 2. So, huwag po kayo malito para mabilis yung maalala. And then, what are the management of abnormal progress of labor? We have reassess pelvic size. Kung hindi tayo sure, then we call someone na mas better po mag-perform po nito. And then we have reassess pelvic size, presentation, position to rule out fetal-pelvic disproportion, expectant management if without CPD, and then provide support to the mother. Okay, kausapin si mother. Kasi this is a do or die, di ba? May fear. So, or the excuse me. Yeah. Abnormal progress in labor. So, let's move on sa ating arrest disorders. Okay, ano naman si arrest disorders? It is active phase disorder characterized by lack of descent and dilatation. Even uterine contractions are occurring normal. So, normal ang contraction, pero yung pag-dilate is lack of descent and dilatation. So, we have three types: arrest of dilatation, arrest of descent, failure of descent. Okay, di ba? Naalala nyo, engagement, di ba? Di ba? Flexion, descent, ganyan-ganyan. So, pag sinabi natin arrest of dilatation, no progress in cervical dilatation for more than 2 hours in NALI. Okay, 2 hours daw sa NALI and 1 hour sa multiparas. How about arrest of descent? No progress of fetal descent for more than 1 hour in NALIs and primis. Almost ano lang din, 1 hour. The failure of descent action of the fetal descent is the second stage of labor. Then lastly, we have prolonged second stage. So median duration in nulliparous is 20 minutes and 50 minutes in multiparous. So 20-50. So the most common cause is the persistent occiput posterior and epidural anesthesia. So prolonged if more than 2 hours without conduction analgesia, 3 hours with conduction analgesia. 2, di ba? Sa NALI is 2-3. Sa multi is 1-2. So, medyo mas short pag multi na talaga. It's okay na tumagal sa NALI, wag lang sa multi. Okay? So, next we have retraction rings, physiologic retraction ring. So, pag sinabi natin physiologic, okay, boundary between upper uterine segment and lower uterine segment that normally forms during labor. So, during labor lang po ito nangyayari, the physiologic retraction ring. So, pag sinabi natin bundles ring, a pathological retraction ring that forms when labor is obstructed caused by cephalopelvic disproportion or other complication. Okay, CPD means cephalopelvic disproportion. So we have upper segment continues to thicken, and then the lower segment continues to distend, and then lastly, we have risk of uterine rupture. So, bundles ring po yan, guys, ha? Okay, pathologic retraction ring that forms when labor is obstructed caused by CPD or the other complications. So, usually, sinasabi po nila dito ay CS. A CS po si patient pag may gantong case. Okay, guys. Pag sinabi natin constriction, kanina retraction. Ito, constriction ring. Retraction ring forms and impedes fetal descent. Okay, impedes fetal descent is a constriction ring. Diba? Dilate. Lalaki yung dilate, constrict, liliit. So, ito ay para liliit. So, relaxation of the constriction ring with analgesic anesthesia or both allows vaginal delivery. Okay, so we're done with premature labor. Parang tapos na din tayo sa precipitate. So guys, precipitate labor and birth. Okay? Ito yung agarang panganganak, di ba? Kaka-start lang ng contraction, biglang nanganak na. So, ang tawag mo dyan is precipitate labor and birth. Okay? So, pag sinabi natin precipitate labor and birth occurs within 3 hours from onset of contraction to delivery. So, within 3 hours or less than 3 hours, consider them as precipitate labor and birth. Okay? Occurs without warning, di ba? Usually, yung tita ko doon, di ba, G6 na siya. Ala, naka-cross leg siya kasi lalabas na talaga. Di ba? Hindi siya nag-umiiri pa. Okay? So, what are the classification? We have precipitate dilatation and precipitate descent. Di ba? Ang daming role ni descent. So, pag sinabi natin precipitate dilatation, 5 cm or more or R per hour, dilatation in nullis. So, 5 cm every hour. Pero pag multiparas, parang after an hour, agad nang mag-full cm. Okay? Precipitate descent is, fetal descent is progressing at a rate of 5 cm or more per hour in 5 cm daw pag nali. Pero pag multi talaga, maya, manganganak na yan, 10 cm na agad. I-engage na yung ulo. So, what are the predisposing factors? Sabi ko sa'yo, pag maraming anak, pag malaki ang pelvis, ayan, lax unresisting maternal tissue, small baby in a good position, induction of labor, and absence of painful sensation. Okay. Maternal risk. Sa mother, magkakaroon ng laceration sa birth canal and uterine rupture. Bigla-bigla kasi ito eh. Then postpartum hemorrhage kasi nagkaroon ng sudden gush of blood, di ba? Dahil, ayan na eh, biglang lumabas sa si baby. Gugunting ka pa ba? Siyempre, hindi mo na mahabol yan. So, amniotic fluid embolism. Pwede din, guys. Then, fetal risk, siyempre, hypoxia or fetal distress. Intracranial hemorrhage, biglaan eh, biglang lumabas. Or pwede din herb di ko na Dutching, or palsy. Di ba parang Bell's palsy lang, nag-rest yung mukha niya dahil may na-touch na neurons or spinal cord. Then premature separation of placenta. And then pwede magkaroon din ng injuries. Then signs and symptoms, we have patient complaints of a sudden intense urge to push. Di ba? Wala, parang nafe-feel ko na ire ako. Di ba kakasabi lang ng 1 cm. Tapos, wala, Dok, nafe-feel ko na mga anak ko talaga ako. Di ba? Yung doktor na, hindi, matagal ka pa, first time mo. Di ba? Actually, may mga ganong bagay. Ganon silang inaano. And then, sudden increase in bloody show. Sunod-sunod yung paglabas ng dugo, parang nagme-mens na. And the sudden bulging of the perineum, biglang tumaba yung pekpek. And the sudden crowning of the presenting part, kahit kakasabing 1 cm lang kanina. Diba? And then, what are the management? We have anticipatory guidance for prevention during oxytocin, admin, stop infusion right away, and turn woman on her side. Kung ganito lang guys, di ba, dahil mabilis lang ang precipitate, usually, stop na yung oxytocin kasi pag too much oxytocin Wala pang seconds yan, baka bigla lumabas. Okay? Then, call for help. Do not leave the patient alone. They obtain sterile delivery pack if in a healthcare facility and then deliver the baby. Okay? Usually nga, sa normal spontaneous sleep nangyayari. And then last, we have uterine prolapse. Okay? Iba ang cord prolapse sa uterine prolapse. So, pag sinabi na yung uterine rupture, it is a tearing of the muscles of the uterus. Okay? Rare but serious complication occurring in 1 in 5 to 2,000 births. So what are the causes? Rupture of scar from previous CS. Prolonged labor, obstructed labor, malposition, malpresentation, overdistension of the uterus, okay, injudicize, use of oxytocin, forceps and vacuum extraction, precipitate labor and delivery, manual removal of the placenta, external trauma, placental increta or accrete or denomoniasis. Okay? And then, gestational trophoblastic neoplasia. So, that's kind is parang cancer na din po. So, signs and symptoms is impending uterine rupture is often manifested by a pathologic retraction ring is obstructed labor. Then we have sudden sharp tearing pain during the peak of contraction, after which relief is felt as uterus loses the capacity to contract. So, nafe-feel nila sa may puson area to guys, sa puson area, nakalocate to. So, what are the types? We have complete, incomplete. So, pag sinabi natin complete, sudden excruciating pain at the peak of a contraction, the contraction stop altogether. Okay? So, bigla-bigla daw nag-stop. Di ba, intense yung sakit, tapos bigla mag-stop. Then, 2 swellings will be visible. Internal hemorrhage. Vaginal bleeding may or may not occur. Separation of the placenta leads to hypoxia and fetal death. So, that's a complete. Pero pag sinabi natin incomplete, ano pinagkaibahan? Masakit. Kung kanina, excruciating pain, dito is localized tenderness. Persistent pain over the abdomen. Contraction may still continue or stop. No progress in cervical dilatation. Then, vaginal bleeding may or may not be present. Then, signs of maternal shock and fetal distress. So, yan yung ating fetal incomplete rupture. So, what are the management? We have to, sa complete rupture, we have to manage the shock, blood transfusion, administration of intravenous fluid, then administer mass oxygen at least 8 to 10 liters per minute. Then, incomplete rupture, hysterectomy, emergency laparotomy to deliver the baby. Okay? So, nursing assessment is sudden sharp, lower abdominal pain, tearing sensation, signs of shock, fusion of contraction, FHR, or the fetal heart rate. Ceases blood loss is often concealed. Fetal parts may be easily palpated through abdominal wall. So, what are the top priority nursing diagnosis? Siyempre, the risk for injury, impaired gas exchange, and deficient fluid volume. So, the planning implementation is, anong pinaka-the best? You have to identify the clients at risk and avoid hyperstimulation of uterus during induction. Na, huwag mo kamutin yung tiyan mo. Na, huwag mo larin yung utong mo, di ba? Plus pa natin yung kanyang swero para hindi magkaroon ng induction of contraction. And then, evaluations. Siyempre, ito yung memet natin. Client and infant are delivered without injury. Then, client's fluid volume is restored to normal. So, I think that's all for your midterms. Actually, marami siya. Pero guys, I will send the topics na lang. Pero ito lang po yung mga lalabas. Hanggang dito sa last part na to. From first page to this last page. Kung sinend ko, yun lang. Wala nang iba. I told you guys, no? So, pag may sinend ako ibang slide, ibig sabihin, iba pa yun. Part siya ng midterms, pero hindi ko pinagkuhanan ng exam. Okay? So, pag may question kayo guys, you have to ask me direct message. Check naman po ako, lalo na pag di naman natabunan, no? So, I think medyo maluwag-luwag po naman ang messenger ko. So, you have to ask na lang pag may gusto kayong itanong. And then, nasa sa inyo na yung kung papanoorin nyo itong video na to, pero it will help you a lot. Okay? So, God bless sa exam you. I hope may maka-perfect pa yan or mapasang. Okay? So, thank you so much again for your time. See you all tomorrow. I think tomorrow, no? Kung may time or may may mga bagay na pagkakataon na pwede tayo magkita. Diba? So, thank you so much again. Thank you for your cooperation as well as kung may mga natutunan kayo, hoping talaga. Kasi ma-apply nyo po ito sa hospital. Okay? Or any lying-ins or any hospitals or clinics na nag-accept po ng delivery process or delivery position. Okay? So, thank you so much again. Ingat kayong lahat and God